Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is the role of the dietitian in cancer care, and our guest is my colleague, Liz Carlyle. Welcome, Liz.
Thanks for having me.
So Liz has just recently joined us a couple months ago at the MercyOne Cancer Center. So we're going to talk about the role of the dietitian. But before we do that, let's just get to know you.
Okay.
Where are you from originally?
I am from Carroll.
Okay.
So not too far from here.
And I know Carroll has two high schools.
They
So which
do.
high school did you go to?
I went to Kemper.
Kemper.
Yep.
And how many were in your graduating class?
I think I graduated with 63.
Okay.
Yeah.
And what was your personal claim to fame at Carroll Kemper High?
I was a swimmer.
Okay.
Yes. So Kemper did not have a swim team, so I swam for Carroll.
Uh-huh.
Yeah.
And did Carroll have indoor pool with the high school, or was it a city indoor pool?
Yeah, the rec center.
Uh-huh.
Yeah.
And was it 25 meter or
25 yards.
25 yards?
Yeah.
Yes.
Mhm.
And so what was your best events in swimming?
I unfortunately was good at the 200 and 500 freestyle. So I was a distance swimmer.
Okay, distance swimmer.
Yeah.
Okay.
Yes. Yeah.
And did you know you had that natural ability for stamina, or was it like we've already got somebody in the other events? Why didn't you try the long event?
I think that's what happened.
Okay.
Yeah. I thought I got put in it as a punishment. And my coach was like, no, we just really don't know what to do with you. And I ended up just being really good at it.
And that's all freestyle,
Yes.
correct?
Yeah.
Okay.
Yeah.
So then once you kind of got put in those distance ones, you didn't have to really focus on the other strokes, or?
Not really.
Okay.
Sometimes he had me swim off events, but I mostly just swam distance.
Okay.
Yeah.
And did you have a good team? Did you make it to
Yes,
state?
We did.
Okay.
Yeah. Yep.
Good.
Yeah.
And did you have personal success?
I did. Yes. So you can make it to state as a team and individually. They take the top, well, they used to take the top 24 in the state. So I made it my junior and senior year in my individual events. Yeah.
Great.
Yep.
And then what did you do after high school?
I actually went to Grandview my freshman year because I thought I wanted to be a nurse, and I quickly decided that wasn't for me.
Okay. What was it about the nursing school? Organic chemistry, or
Well,
drawing blood, or
kind of, yeah, the care.
okay.
I was like, it takes a very special person to do all of that. No, it wasn't the chemistry because I still had to take all of that.
Right.
Yeah, so quickly decided that wasn't my route, and then I transferred to Iowa State.
And when did you the profession of a dietitian come onto your radar?
I've always been pretty interested in nutrition, all through high school and stuff too. And then I ended up job shadowing a Hy-Vee dietitian while I was at Grandview, just to make sure, this was kind of where I wanted to go because it's long schooling. And yeah, I just kind of fell in love with what she did. So that was it.
So you transferred to Iowa State.
Yes.
And graduated. And it's the undergrad degree called nutrition, or is it called dietitian?
It's called dietetics.
Dietetics is
Yes.
and then in order to get your credentials to become a certified dietitian, after you graduate from college, you need to do some additional clinical work. Is that right?
Yes. When I was in school, we had to do an internship. So I did that through Iowa State also. And then they placed me in Carroll. So that's where I did my internship. That was about
that was convenient.
I know. Yes. My dad wasn't very thrilled to have me move back home, but just kidding. But yeah, so that was about 6 months. And
did you get your own room back, or did you have to move to the basement?
Okay. I was like, guess what, Dad? I'm coming home. He's like, you're kidding me.
And so when you're at Carroll, did you get to work in the cancer center as well? So they have a nice regional cancer center there,
They
Carol,
do.
at St. Anthony's.
I really didn't get to do a lot, unfortunately. The dietitians there were only 3 of them, so they kind of did everything.
And this was in the hospital.
Yes, correct.
St. Anthony's.
Yes, correct.
Okay.
So I didn't really get to do a lot with oncology, which I was kind of bummed about because I did have a big interest in it.
And so then when you finished the year of clinical training, is that when you sit for the boards?
Mhm.
Okay.
Yep. Yeah.
Okay. And then what was your first job after you got done with all of your training?
Hy-Vee, actually.
Okay.
Yeah. I stayed in Carroll for a little bit and I worked just at our local Hy-Vee.
And what was the role of being the dietitian at the local Hy-Vee in Carroll?
I did a lot of cooking classes, which I liked. And then I did like a lot of store tours, a lot of education. I did a really fun garden class in the summer with kids, which I loved. So yeah, a lot of more community-based things.
And then you decided it was time to move to the big city.
Yes.
Okay.
I was ready.
And so then you came to Des Moines.
Yes, I transferred Hy-Vees. I was actually working in the pharmacy at the time because COVID happened. Lots of things went down and I got put in the pharmacy. So I became a certified pharmacy technician for a few years.
Okay.
So that's how I got to transfer to a different Hy-Vee to get down here. And then a position at the Mercy Hospital opened up for dietitian. So
then you had to brush off your
yeah, for sure.
dietitian credentials and
Yep.
brush up on everything you had learned.
Yeah.
And then you joined the cancer center 2 months ago.
I did.
Right. So let's talk a little bit about the various roles that you play at the cancer center. So I often think, and I'll sort of put this out here and have you correct and elaborate. There's sort of 2 general issues, and you probably list 5 others that dietitians play in a cancer center. And I sort of think of it as one is like people are having issues maintaining nutrition and hydration because of their cancer and because of the side effects of treatment. And then the other big bucket is that some of the cancer treatments, especially in breast cancer, end up slowing down the metabolism. And after you're done with the anti-cancer treatment, you have trouble with gaining too much weight. And so sort of 2 opposite problems, but both are common in the cancer center.
Yeah.
Are there other kind of we're going to dive into each of those, but other general categories that you get called in for?
Yeah, so the nutrition when people are struggling eating during their treatments and stuff, that's probably the biggest one I'm getting. I've been pulled into a lot of the head and neck cancers who have to get what's called a tube feeding placed because they aren't able to eat or swallow or do any of those things well during treatment. So been pulled into that aspect of it too.
Yeah. And that gets a little bit more technical.
Yeah.
So it's one thing if somebody has a bit of nausea, difficulty swallowing, but we're still trying to get them to get all their nutrition orally. But then it's different if they're getting their nutrition through a feeding tube. Some math involved there.
Lots of math. Yes.
So talk a bit about, let's take, for example, a hypothetical case of a gentleman who's been diagnosed with cancer of the tonsil, which is often caused by HPV virus. And treatment is often a combination of radiation therapy once a day, Monday through Friday for 6 or 7 weeks, along with weekly chemotherapy. So they might come in at the beginning totally able to swallow.
Yes.
But we anticipate that during the course of the treatment, they're not going to be able to swallow. So we often, even though they can swallow, have a feeding tube put in.
Yeah.
Describe a bit what type of feeding tube that is.
So it's called a G tube usually, and it just goes right into your stomach. And we just bolus what's called tube feeding just right into the stomach typically. Yeah.
And a patient can do that themselves.
Yes. Yep. usually.
Yeah. And so while they're still able to eat, even though they have a feeding tube, they can still eat and drink.
Yes.
But
Yep.
we put it in
Encouraged.
because we know that there's going to become a time where their throat is so sore and they have a dry mouth and things don't taste good that they just would not be able to maintain their weight or nutrition.
Yes, and we want to stay on top of it because if somebody decides they don't want to get the tube placed, and we get 3 to 4 weeks into treatment when those symptoms start happening and they want to get the peg, that puts us back with treatment and things like that. So we always just kind of recommend getting it placed beforehand. The goal is to not have to use it, but majority of people end up using it, but they're still able to eat by mouth more for pleasure and to just keep those muscles working.
So some, you probably, when you're in the hospital, saw patients who had a nasogastric feeding tube. Maybe describe what that is and how that works.
So that's the one that goes down your nose into your stomach. And it's just kind of essentially the same thing, just a different route. It can go into the stomach or it can go into your small intestines, depending if you're having issues or anything. So that's like the major difference is just the placement of it.
And the disadvantage is you've got this tube hanging out your nose.
It's very uncomfortable.
So for someone in the hospital, it might not make a big difference, but most of our patients are out and about, and having that tube is just cosmetically doesn't look good, doesn't feel good. So the route of going directly into the stomach just is more presentable and easier to manage for the patients.
Yep, you can hide it pretty easily with your shirt, or they make bands even that we've been recommending to people that can kind of just help support it, but also hide it and things like that.
When you are helping to care for a patient that's going through 7 weeks of radiation and also chemotherapy, how frequently do you see the patient?
Usually at least once a week if they need me, whenever they need me, really. But yeah, for sure, at least once a week, just to make sure they're still eating well, they're not having the side effects. If they are, what can I do to help? And just really making sure they're maintaining weight and muscle mass.
And does pretty much every patient get started on the same type of feeding, the same liquid?
Typically, yeah, we like to start with a standard, just generic tube feeding. Some people do have to get more specialized if they can't tolerate the regular one that we use.
What about patients with diabetes? Do they get the same type?
We start them off on the same type for insurance purposes. Insurance doesn't always like to cover the specialty ones unless there's a specific reason. But yes, they do make a special one for diabetes, renal, and things like that too.
So people with kidney issues, you also may have to change the formula a bit.
Yes.
Okay.
Yeah.
And when it goes in directly into the stomach, do patients still have a taste of it? Do you use flavored versions, or if it goes directly in the stomach, bypassing the mouth and the taste buds, is there any sensation of taste?
No, some people who have like the NG have kind of told me that they think it's come back up a little bit and they can taste it.
Like if you were to burp, but you probably would taste what it is.
Yeah, it doesn't taste great.
Okay.
Yeah.
But since they mostly can't taste it, you don't spend the extra money on the flavored versions.
Correct. Yeah.
But if somebody were to be drinking this, we would do the flavored versions.
Yes. Yep.
Okay. So I'm sure you've tried all the different varieties.
We have.
What's your favorite of the flavored versions?
Of the flavored versions? Like just the ones we carry in the hospital, or generic?
Whatever you think is the best flavor.
Well, I really like strawberry flavored things.
Okay.
That one's pretty popular.
Okay.
Otherwise, chocolate's always a go-to for me too.
Yeah. And what's the most popular for the patients?
Strawberry or chocolate.
Okay.
Yeah.
So what are some of the other issues besides the head and neck patients? Again, we're talking about not the patients that need to lose weight, but the difficulties the patient might have with swallowing or with digestion that you get involved with.
Mhm.
And I'm thinking maybe like pancreas cancer patients.
Yes. Haven't worked with a ton yet since I've only been 2 months in, but a majority of the time they'll have to be on what's called a pancreatic enzyme because their pancreas isn't working correctly to help digest fats in your body. So they'll just have to take those while eating meals to kind of help digest all of the fat.
And that's usually just a pill.
Yep.
That has the enzymes because their pancreas may not be making enough of the enzymes.
Correct.
And so from a nutrition dietitian point of view, where do we get the different enzymes that help us, and how do enzymes help us get the nutrition from the food we eat?
Oh my gosh. We can get enzymes, just our different organs make them in our body. So
does some of digestion start in the mouth? Does our saliva contain start to help break down the food?
So carbohydrate digestion starts in the mouth, fat and protein start in the stomach. Yeah. So when those hit our stomach, that's kind of when like our liver and our pancreas and our gallbladder start releasing all of those enzymes to help digest all of our food. Yep.
And have you gotten involved yet in patients with liver cancer or biliary cancer where their whole bile process is altered because of the cancer?
I have not.
Okay.
No, not yet.
And what about special situations maybe involving colorectal cancer?
I have had a couple of those, yes. Yep.
And what are the conversations you have with those patients primarily consist of?
Fiber.
Okay.
Because a lot of them experience either diarrhea or constipation with the radiation that they're getting down in that treatment area. So if they are experiencing constipation, I recommend they start eating insoluble fibers. So those are going to be like your whole grains, things like that, fruits and vegetables.
So if I were at my Hy-Vee where you no longer work, what would you have me buy in terms of real food?
In real food, any type of fruit and vegetable.
Okay.
Things like that have skin on them are going to be the best options for fiber. If you like to eat the skin of fruits and vegetables, that's where it contains the most fiber. Yes, even in kiwi, even. So I know it's got a weird outlining, but it's not that bad.
What are your favorite foods for recommending for fiber in terms of real foods?
And then I recommend any type of whole food. So whole grain breads, whole grain pastas, brown rice is a really great option.
Okay.
Any types of beans and legumes are going to be high in fiber too.
What about, two of my favorites are eggplant and okra as being good for fiber. And are you familiar with the concept of pre-inulin? Okay. So it's in those sorts of foods that have a kind of a mucus, like the center of a eggplant or the center of okra.
Okay.
Or how about psyllium seed foods?
Yes. So those are more of your soluble fibers.
Seeds.
Yep. So seeds, oats, bran is a really good option. And again, fruits and vegetables and beans and legumes and things like that. Yeah.
And then let's kind of shift gears, because another big component of issues related to nutrition. So for example, with early stage breast cancers, 80% of women going through breast cancer treatment gain 20 pounds or more, which is just like totally unfair.
Yeah.
But oftentimes women might be at the edge of menopause, and by the time they get through the cancer treatment, they've been slammed into menopause and then are taking anti-estrogens, either tamoxifen or aromatase inhibitors that can slow down the metabolism. And so all of a sudden you go from I've been very active and maintaining my weight to I'm having a difficult time just keeping my weight at what was normal.
Yeah.
What's the process of counseling individuals about weight gain and how to get them back on track.
Okay. Haven't really worked with anyone on that either. But really, I just, in general, for anybody, I just tell them to focus on whole foods, making sure you're pairing a carbohydrate and a protein with each meal, because that will help keep your blood sugars stable and not drop, and just keeps you fuller longer throughout the day. So you're not constantly snacking and things like that too.
So you mentioned protein. I think one issue that often comes up is, where do we get our protein? I think kind of most of us grew up in the Midwest think we have to have meat every day. That meat, everybody knows, is a source of protein. But I've been told that you could be a vegetarian and still get all the protein you need. So what are the best plant sources of protein?
For plants, there's not a ton. Beans and legumes are a good source of protein also, and then any type of nut or seed is going to be a good source of protein. Others are really any dairy product, so milk, cheese, yogurts, and then eggs are a really good source of protein too.
And for most people, those are pretty palatable when we're trying to get people that might have like the beginning of treatment that are still consuming orally. Egg whites are pretty much 100% protein and slide down pretty easy, even if you have some nausea issues or swallowing issues.
Yeah. I have noticed proteins become quite a big topic in general nutrition these days, and they're kind of making everything with protein, it seems like these days. So it's getting a lot easier to find products that contain higher protein. So
yeah, you see things that are like wouldn't normally have protein, like almost like soft drinks that you know, that are almost like soda pop, but they're labeled as having protein. Do you know what type of protein they're putting in those?
I think it's usually just a whey protein.
Okay. Which is from milk.
Yep. Yeah. I know. I even saw like protein Doritos at the store the other day, and I was like, oh, we're getting the chips even. So, but not that I would recommend those, but.
So, you know, talking about nutrition is much more common than it was 20, 30 years ago. And I think most people have some sense of understanding, but now we have lots of different diets that some people just promote, whether it is a Mediterranean diet, a keto diet, paleo diet, fasting or intermittent fasting. So if someone comes to you and doesn't have a preconceived notion about what diet, how do you talk to them about assembling a diet? Or I should say just an eating plan.
Sure.
Because the word diet often conjures up restricting calories as opposed to here's what you eat.
Yeah. So I typically try and avoid the word diet just because of the stigma behind it.
Yeah. What words do you like to use instead?
I just talk about healthy eating in general. So again, just with anybody, I'm always making sure they're incorporating the whole foods and incorporating carbs and proteins and fat in every single meal or snack.
And those, you mentioned those several times, those are kind of considered our macro nutrients. Like everything is pretty much fits in there. And then there's the other stuff like vitamins that generally speaking don't have any don't have any calories associated with them.
Correct. Yeah. So carbs, protein, and fat are our body's main sources of energy and stuff. So yeah.
And do you have a rule of thumb for what that percentage should be for the average person?
I used to. Carbs should be at least 50%. Protein is 20%, and I think fat is 10%.
Okay.
Yeah.
Doesn't quite add up to 100.
I know it doesn't. So somewhere in there, that range. Yeah.
Okay.
Yeah.
And what do you think is some of the main barriers to people maintaining a normal body weight? And again, I'm talking at the end of treatment where being overweight is more of a problem. What's the barrier to going from overweight to normal weight?
Probably just the foods that they're consuming. A lot of people don't just know what is in their food. So yeah, again, just going back to eating whole foods, making sure you're eating plenty of fruits and vegetables, any type of meat, whole grains and things like that.
Do you like to recommend people keep a diary?
Sometimes,
so that they actually know what they're eating?
If that works for them. Okay. Some people overthink it and it kind of becomes a barrier to their goals. So I just really talk about portion control and just mindfulness of when you're eating. Yeah.
Okay. What are some of the other issues that you experience either when you're on the floor in the hospital? I guess we haven't talked about another very special type of nutrition, and that is TPN.
Oh, yeah.
And were you involved with that in the hospital? And maybe explain what does the TPN stand for, and why would somebody be getting that type of nutrition?
So TPN stands for total parenteral nutrition, and we give it through a PICC line. And it's basically carbs, proteins, and fat in its already like digested form, and it's going straight into your veins instead of your stomach. So your body can absorb it a lot quicker. Just like some scenarios that we use if a patient had some sort of blockage in their intestines, an ileus, a new like colostomy, things, if their digestive system's not working correctly was our first indication that they need TPN.
So they can't, obviously if the digestive system is working, it's easier just to put a feeding tube into the stomach and let the food go there. But for those where the digestive system isn't working, getting calories, very technical feeding to go directly into the veins. You can't just,
you have to be very cautious.
Mash up some cornflakes and
right,
put it in the veins.
Yeah, luckily I only had to figure out the substrates, so the carbs, protein, and fat. The pharmacist did all of like the vitamins and minerals, thank goodness, because that's a lot.
Yeah, so it's really a highly technical, almost like a medicine rather than a real food.
Yes.
You don't just go down to Hy-Vee and then put it in the blender.
Yeah, correct.
Yeah.
Can't go buy it off the shelf.
Okay.
Yeah.
So what's been the most professionally satisfying part of your job as a dietitian in a cancer center?
Just helping people be successful and watching them complete their treatment, and just making sure they've met their nutrition goals throughout the treatment too. So, but watching them complete their treatment in general has been the most satisfying part.
Being able to get rid of the feeding tube.
Yes.
Because they've been able to go back to maintaining their hydration and nutrition.
Yes.
Okay.
Yeah. Haven't had anybody get rid of it yet, but we're working on it. So, yeah.
Are you game for some questions from we've got a large studio audience here, so they are going to get the opportunity to ask the first question.
If they're easy questions.
You are watching us live streaming right now, you can ask questions to Liz, and you could put the questions into the comment section of the software you're using to watch us, and we'll be looking out for those questions. But we'll start off here first. Boone, do you have the first question for Liz?
Yes. Hi, Liz. How much protein grams wise would you recommend for someone after treatment that does work out.
Yeah.
And then there's a second part to that question as to a protein drink after a weight workout.
Sure. So anybody going through treatment, their protein is increased quite a bit just because your body's going through a lot. And then when you're done with treatment, try and recommend they continue that same grams of protein. So everybody's different because it's based off of your weight. Generally speaking, I'll just say I figure it out in kilograms of your body weight. So if somebody's 77 kilograms, you would want to start your baseline at 77 grams of protein, and then you can go up from there. Makes sense. Yeah. Yep. It's, yeah.
And Poon, as you hear that answer, is that something that you have been calculating when you are at home?
No, so I'm a pescatarian.
Okay.
So I tried to, and just this last year I started adding a protein shake after because I never liked the taste of
Sure.
it. So now I've found some that I like. So like after I work out,
Yeah.
I'll have about 20 grams of protein shake.
Yeah, that's perfect.
Yes. Yeah.
And Liz, is there a particular timing for after a workout, let's say strenuous workout that includes resistance training to build muscle mass? Is there any studies that show that there's an optimal time to consume the protein?
I've read anywhere between like 30 minutes up to 2 hours is where you want to get that protein in.
Okay.
Yeah. And they usually recommend anywhere between 20 and 30 grams after workouts.
Okay.
Yeah.
Next, Tim.
I don't know if this is a quick question or not, but I'm kind of fascinated about having the hole in the stomach and being fed through that
Sure.
hole into the stomach.
Yeah.
And there's a situation where people get that full sensation to say, "Oh, I'm too full. I can't eat anymore." Things like that. So, do your patients have that type of thing that happen to them? They say, "Well, I already had my pouch of Wheaties or something like that. I injected in, and I still feel hungry. Or maybe I should get another one."
Yeah.
Do they get that full feeling?
Yeah, they do. Yeah, sometimes, and that's what I always ask in our weekly conversations. Are they tolerating it okay? Do you feel full, or do you feel like you're getting enough? And they'll tell me if they're still feeling hungry, then we can up the feedings a little bit more. Or if they're feeling full and uncomfortable, we kind of back off a little bit. So we try and find that happy medium.
Okay.
Sure. So I try and accommodate it to your schedule. Usually breakfast, lunch, and dinner. So 3 times a day. The patient's not tolerating the amount that I'm recommending, we can kind of break it up too, but usually about 3 to 4 hours in between each feeding.
And just to kind of amplify, so some patients might just do bolus. So just like, you can drink a whole glass of milk in 15 seconds. Some people can.
Yep.
You can squirt liquid feeding in quickly. It's the stomach. But some people who have some nausea, or it might be better to do smaller feedings more often.
Yep.
And there's some situations where you can hook the feeding in almost like with a pump that just slowly drip by drip. So kind of like a pump that regulates an IV. You can also use one of those that regulates, and over the course of like 24 hours, it just slowly methodically puts in drip by drip. For most people who have a good digestive system, you just take some time and, over 10 minutes or so, just squirt in quite a few ounces if you're going to do 3 feedings.
Yep. Yeah.
Yes, Kevin.
You mentioned some people some patients are reluctant to have that tube put in. I had one put in. It's my bullet hole now, but it was a tube then. And I found that I really didn't want to get off of it.
Really?
It was so convenient.
Yeah.
I mean, you didn't have to go shopping. You didn't have to cook anything.
That's
10 minutes and you were done. You didn't have to clean anything up, really.
Yeah.
And Kevin, so you used it, and what was your experience like? Did your throat get so sore that you would not have been able to maintain your weight?
Well, I lost a lot of weight and my throat was sore, but so
But you were very happy that the feeding tube was used.
Oh yeah,
Mm-hmm.
but it was. I really didn't see a lot of downside to it at the end of the day.
Okay. Well, thanks for sharing.
You might, if somebody's reluctant, you can tell them what the advantages might be for them.
Yes.
You could learn a foreign language or something in that time.
That's so true.
Think about hobbies.
Yeah, I think people are just reluctant because they're afraid that they won't be able to eat by mouth ever. And people enjoy eating. So I always, say what you kind of went through too, but they still can eat by mouth for pleasure more. But their full nutrition is going to be met by their tube feeding.
Excellent.
Well,
Yes,
thanks
Ron.
for being here, Liz. Do you ever do any blood work to see what people may be lacking in their nutrition?
I personally cannot do that, but majority of patients going through chemotherapy get weekly labs. So I do get to see if they are lacking in iron or vitamin D or potassium, any of those things. So if I do see that, I usually mention that in our meetings and give them a variety of foods to try to get those levels up.
I would say it's probably more common in patients that are getting TPN, which is a very much of a chemical mixture that's going in the veins, where they're actually regulating. With the food in the stomach, it's really can be real food that is either pureed or the mixtures of. So it's not like you're typically measuring the carbohydrates, the fats, the proteins in the bloodstream. So the normal blood work that's being monitored by somebody undergoing chemotherapy is more related to minerals and salts, and also looking carefully at the blood counts that can go down because of the chemotherapy. So rather than doing an assessment of the nutrition that someone's getting, the blood work is done more to monitor how they're tolerating the chemotherapy.
Mm-hmm.
The TPN, though, there's a much more focus on looking at the patient's blood work.
Yeah.
Maybe just another question. Doctor mentioned intermittent fasting.
Mm-hmm.
Say post treatment, what are your feelings on that?
I'm not pro fasting and I'm not against fasting. If it works for somebody, I think that's great. People find it beneficial. I guess personally don't recommend it, just because you need to get your body the nutrition that it needs to just function throughout the day. Just to think, just to breathe, just to do general activities. You always need to start with some sort of nutrition.
George.
Yeah, I'm just wondering if either one or both of you could talk about the role of proper nutrition from a preventative side for cancer as opposed to a curative side. And is there any confusion out there amongst cancer patients in particular about that?
Liz, you get to go first.
Oh, goody.
What's the best diet that for, let's say, someone who's never had cancer, the best diet that can help prevent cancer?
Yeah. So I wish there was one specific diet I can say, if you follow this, you're not going to get cancer. But I know I've said this many times, but it's just incorporating all of those whole foods, making sure you're getting adequate fruits and vegetables, because that's where you're going to get all your vitamins and minerals and your antioxidants. to help prevent cancer, making sure you're getting good sources of protein and healthy fats in your diet too, and whole grains and things like that.
And just to elaborate, I think, sorry, highly processed foods are really implicated in being a bad diet. So maybe Liz, talk a little bit more about what is a highly processed food and how do you avoid eating highly processed foods?
Yeah, so highly processed foods are usually going to be a lot of like your frozen meals or things that have very long shelf lives and like deli meats and things like that too. They just contain a lot of stuff in them to keep that shelf life longer and things like that. So that's kind of the foods I'm talking about, like staying away from and focusing on more of the whole foods.
Foods that look like what they are.
Yes, correct.
So often going around the outside of the grocery store.
Correct.
So, a piece of chicken that looks like a piece of chicken.
Correct. Yeah.
A potato that looks like a potato. In the most natural state, you're going to get the foods that aren't processed.
Yep.
Now, minimally processed. So, for example, you buy a can of vegetables. Clearly, they've been cleaned. They've been put in a can. They have something in them, but they're minimally processed. It still looks like a can of beans. So you don't always have to take the dry bean and spend 2 hours cooking them to soften them. A can of beans that has just been cooked, but doesn't have 12 other products that you get. So those are minimally processed. I kind of think oftentimes tofu, not my necessarily favorite, but it's often touted as a health food. Well, it doesn't look like a soybean,
right? But
it is a minimally processed food compared to, something like a salami is a very highly processed food that has been you don't know what part of an animal is in that, and it has been very, very highly processed and doesn't resemble the cut of meat that it came from. What are other rules of thumb for deciding if this is a highly processed food versus minimally processed versus unprocessed?
Really just kind of reading the ingredients in foods too. They always say if you've got a long list of ingredients in that food, that's typically a highly processed food. So I always kind of say the less ingredients, the better. Yeah.
Okay.
Yeah.
Next question.
Yeah, I just had a kind of a observation. Maybe it's more for Dr. Deming. Back in the 70s and 80s, even there were people that these fad diets. You mentioned some of the acceptable diet stuff today, but I'm thinking about people that thought they could cure cancer by eating carrots.
Right.
Things like that. I mean, is that no longer a thing? I mean, you don't have people coming for cancer treatment that believe, they need to have a diet of carrots, as an example.
You don't see that one. I mean, you do see, was there a sauerkraut diet that was popular for a while?
Yeah.
And sometimes you'll see fads like that. I think I don't personally see that so much. I think people do have questions about keto diets and fasting. And as you pointed out, well, you do need nutrition every day, and that the role of fasting, I think, is controversial. And then how do you define intermittent fasting? So most people do intermittent fasting if they don't eat from dinner time till breakfast. That's really 12 hours, or longer. So. But there's research being done on that. And same with ketogenic. Do you want to talk about ketogenic diet? Do you have how do you define as a dietitian a ketogenic diet?
A keto diet is a diet very high in fat and very low in carbs. I believe you're supposed to only eat like 20 to 30 grams of carbs per day and then get the rest of your nutrition through fat
And protein.
and protein. Yes, but majority fat.
Fat.
Yes. Yep. The keto diet, I knew it in school because it's supposed to help prevent seizures. So they put a lot of kids on the keto diet who are having a lot of seizures. So that's how the diet kind of came about. And then I think people kind of put it together with weight loss too. You're sending yourself into what's called starvation mode, and your body's trying to burn all the fat off instead of utilizing the sugars that your body would normally need to function.
Gary, do you have a question?
Yeah, I have. You mentioned the vitamins and minerals and supplements and stuff.
Mhm.
You often, recommend those vitamins and minerals, or do you think that just what we eat, we should be able to supply the necessary ingredients for our bodies?
Yeah, typically what you eat, you should be able to get the majority of what you need. Some people don't always eat that stuff. So you do need some supplementation every once in a while. That's why they're called supplements, because we would rather you get it from food itself and then supplement as needed.
Great. Poon.
In the winter, we don't get our vitamin D,
Correct.
so
Yeah.
I like to take that with Kate too. Do you recommend like a fat with that avocado or eggs with, of course, with a meal, but some type of fat with
To help,
vitamin D?
to help absorb it?
Yes.
Yeah, absolutely. Yeah, any type of good fat will help absorb all of that stuff. Yeah.
Okay.
And yeah,
Any other questions for Liz? Well, Liz, this has been wonderful. Thank you for being with us.
yes, of course. Thanks
And
for
so
having me.
our guest tonight has been Liz Carlyle, oncology dietitian at MercyOne Cancer Center, and always a popular topic. If you know someone that would benefit by watching this program, good news, it's available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer site website. So I hope you'll join us again next week. Thanks, everyone. Thank you.
Thank